Hello everyone, my name is Haley Blackwell and I am a Doctor of Nursing practice student at Maryville University. I am presenting on my DNP project, which is improving nurse practitioner clinical procedural skills in community health centers.
And these are my committee members, Dr. Maria Snell, Dr. Boniface Steigman, and Dr. Tiffany Stewart.
This DNP project is based on the clinical problem of inconsistent clinical procedural skills, or CPS training, among nurse practitioners, or NPs. Several studies, which we will discuss in a minute, show that NPs feel there is inconsistent training through didactic instruction, clinical rotations, and on-the-job training. They felt they were not ready for the procedural aspects of primary care after graduation. Studies also show a shortage of rural and underserved community providers, with NPs commonly filling this gap. Still, the NPs in these studies suggest more CPS training is needed to feel more prepared for the complex patient population. So a little background on me is that I've been a primary care family nurse practitioner for 4 years. I didn't receive any CPS training in my master's program or during clinical rotations. And I work for a large 20-site community health center, CHC organization, and it's about an hour away from any hospital or urgent care center. CHCs are supported in various ways, such as through grants, and they help to provide underserved communities access to care. We have 49 NPs and we provide over 200,000 visits annually. We also have 21 physicians. Thankfully, I work with some very experienced physicians and have gotten on-the-job training for many of the procedures that I do. However, I know not everybody, especially at some of our smaller sites in our area, get that opportunity. So I wanted to expand learning opportunities and improve NP procedural visits. My DNP project aimed to implement CPS training in a 20-site CHC to improve access to procedural care and improve NP procedural skills. This quality improvement project implemented a 4-hour in-person CPS training for NPs within my organization. So let's discuss the background for this project. The NPs listed have an overarching theme that NPs generally feel unprepared for primary care procedures after graduation. The first study in 2022 basically ranked the common procedures they performed, and the majority of NPs stated they received no prior training and many did not feel adequate out of school to perform them. The next study showed that 63.1% of NPs performed incision and draining, and 55.5% of them performing laceration repairs, but very few actually had formal training on them. The third study identified how many NPs are often filling the rural healthcare gap and the need to support them from an educational standpoint to be able to handle that type of patient complexity. The fourth study by Owens showed that the rural and underserved primary care setting was challenging for providers, but they had overall improved job satisfaction in the long run because of the constant stimulation and learning opportunities that these areas provided, and I can personally attest to that. The fifth study by Nelligan showed that there is 4 to 5 times more cost effectiveness when primary care providers can perform these in-office simple procedures, as opposed to referring out. The next study showed that NPs tend to over-refer, which increases cost, so improving our knowledge base will also help limit the referrals. The seventh study showed that the NP residency programs are a great addition due to the growth of the NP market, and it helps to increase confidence and job satisfaction early on. And my organization implemented a new nurse practitioner residency program last year, and this project was integrated as a part of their learning opportunity. The last study basically supported how NP residencies can be a great way to improve training and knowledge base and just support additional CPS training for NPs. The population intervention comparison outcome and time, or PCOT question, is: in nurse practitioners who practice at a primary care community health center, does implementing clinical procedural skills training for 4 common procedures compared to pre-training increase procedural visits in 6 months? The DNP project's CPS training focuses on 4 common primary care procedures, which are simple laceration repair, simple abscess incision and drainage, and knee and shoulder intra-articular glucocorticoid injections. 4 themes were identified for this project. The first is a lack of readiness to perform CPS. The new graduate NPs generally feel unprepared after graduation, most notably in CPS. Learning environments vary for NPs, producing inconsistent preparation for the primary care setting. But when CPS training is implemented, it increases the confidence of NPs. Improving preparedness supports the new NP and encourages them to continue growing in the healthcare field, making them a more confident provider. The second theme is the limited resources among patients and providers. These limitations are highlighted in the rural care setting, which is challenging for patients to access specialty care. My organization is about an hour away from any city, emergency, or specialty care setting, and the patients are often limited by transportation challenges. It's also challenging for providers to attend training as they are typically in larger cities, making for increased travel time and expenses. As we all know, finding preceptors and mentors as an NP student poses challenges. This limitation reduces how much NP students are able to experience CPS in practice. The third theme is patient outcomes. There is mixed evidence on if improving access to care directly correlates with improved patient outcomes. That's not to say that improving access to care is bad, but some of the research shows that it highlights the need to improve training opportunities for providers. This is most notable in the primary care setting where there are reduced wait times when procedures are performed in this setting. But again, unclear if that improves patient outcomes. The final theme is cost effectiveness. There is mixed evidence that suggests NPs may be over-testing due to a lack of training and raising costs versus NPs reducing costs by improving patient access, care accessibility in primary care. However, it was unanimous among the studies that primary care procedures cost much less than when the same procedures are performed in the primary care setting. So there are several strengths in the research. Randomization minimizes bias, and a randomized controlled trial was the study designed for Emoako et al. There were 5 retrospective cohort studies in this literature review offering a hindsight viewpoint. 8 out of the 14 publications had either a large number of participants or a large number of retrospective data which further supports this DNP project. There are 7 publications that survey study designs, and they all use clear and concise language. The Want et al. Study used a content validity instrument. The validity of the DNP project is also supported by the findings that endorse the potential for professional growth and improvement for access to care. 7 of the publications were based in the primary care setting, providing additional support for this project. So there are weaknesses, gaps, and limitations in the research. We will start with weaknesses. Surveys increase the risk of response bias as they risk superficial responses and inaccurate self-reflection. 4 publications use cross-sectional data which risk bias due to variable assumptions. The Liu et al. Study was the only quasi-experimental design, but it lacks randomization. Among the surveys, 6 out of 7 did not use content validity instruments. 6 of the 14 publications had limited targeted audiences, and many involved only one organization, increasing the risk of bias. Gaps were also present in literature, with some of the studies showing that identified a lack of readiness among new graduates did not address if that correlated with patient outcomes. They also did not differentiate between MSN and DNP prepared NPs, as this could contribute to response bias. 2 of the studies were not in the primary care setting, limiting the relatability, and there were also several limitations in the research, showing that web-based surveys yielded lower participation, ironically, though they are more convenient. In-person and interview-style surveys tend to produce better participation. And then we can always blame COVID-19 for something, and COVID-19 yielded limited participation due to work schedule demands and childcare limitations in the literature. Gender bias is also inevitable in the NP field due to the female-dominated environment, but this often produced general gender biased results in the literature. So a flyer was electronically mailed to all NPs within my organization. A PowerPoint presentation explained the clinical indications and how to perform the procedures. There was also a hands-on component, and there was a retrospective chart review to determine the number of procedures completed by NPs before and after the CPS training in hopes that the training increased patient access to care. The project design utilized quantitative data to determine the statistical significance of the outcomes for this quality improvement project. 4 training dates were provided in October and September, and 24 out of 49 NPs in my organization attended. The CPS training was held in a centralized location and included didactic training through PowerPoint, followed by a hands-on component which included shoulder and knee mannequins and suture, incision, and drainage kits. A retrospective chart review was used to extract the CPT codes through our EMR system. The data was collected for 6 months before and after the training to see if it increased procedural visits and improved access to procedural care. There were no human subjects involved, and there were no inclusion or exclusion criteria during the retrospective chart review, as the data was collected using only CPT codes. However, this training was only for NPs within my organization, so the ones who attended were then extracted from the spreadsheet and placed into the data collection sheet. This project included quantitative scale data, which was uploaded to the Statistical Package for Social Sciences, or SPSS. This program allowed us to analyze the pre-training and post-training data using the Wilcoxon sign rank test. This test evaluates two measurements from the same group of participants and assessed if there was a statistically significant difference in procedural visits after the CPS training was implemented. My grand total was $4,243.13. The manikins were the most costly, resulting in almost half the entire budget. The next highest was the number of suture kits, as each participant got a kit to practice during the training and then to take home for practice. And then travel time, just because there was 4 training dates and that kind of added up. And then, however, all this practice did teach me a lot about hosting training, and I look forward to implementing that for future ones. The data collection instrument was created before data retrieval and consisted of procedural visits pre and post intervention for NPs who attended the training. In-person and simulation training has been shown to improve procedural competence. This literature inspired me to purposely create the data collection sheet to capture NP procedural visits in hopes of increasing access to common primary care procedures. The clinical director conducted a retrospective chart review and obtained the number of procedures completed by providers 6 months before and after the training intervention. The clinical director abstracted this information into an Excel spreadsheet and gave it to me. This de-identified patient information included the medical provider's name, number of large joint injection visits, laceration repairs, and incision and drainage 6 months before and after training. I placed the nominal and ratio measurements into a data collection sheet and replaced the NP's name with their position to ensure confidentiality. And this is my data collection sheet. The top portion shows the number of procedures before the CPS training, and the bottom portion lists the number of procedures after the training. These were completed in 6-month timeframes. This DNP project was implemented in a 20-site CHC organization in the eastern region of the U.S., seeing almost 50,000 patients annually and about 200,000 patient visits annually. Of this, approximately 75% are Medicaid, Medicare, or uninsured patients. There are 49 NPs employed within this organization, with 3 being NP residents. Of these, 21 NPs and 3 NP residents attended the CPS training. The organization had 21 physicians and no current physician assistants. There is no current CPS or skills-based training within this DNP project organization. And this product aimed to improve access to common primary care procedures and equip NPs with the educational tools to improve this care gap. The data collection included NP procedural visits for these procedures before the training from March 26, 2023 through September 26, 2023, and then after the training from September 27, 2023 through March 27, 2024. The retrospective chart review found 35 pre-training and post-training large joint injection visits, and there were 4 simple laceration repair visits before the CPS training and then 2 after. The retrospective chart review also revealed 9 pre-training simple abscess, incision, and drainage visits and 13 post-training visits, which were among the 21 CPS training participants. The NP residents were excluded from the data collection because they were not present in the 6-month pre-training timeframe period. A Wilcoxon sign rank test was calculated to compare the mean NP procedural visits before and after the CPS training intervention, as shown in this table. Each set of the data significantly violated the assumption of normality, supporting the need for a non-parametric statistical analysis. The mean rank pre-training joint injection level was 4.50 and the mean rank post-training was 5.63. No significant difference from pre-training to post-training was indicated for joint injections with a p-value of 1. The mean rank pre-training incision and drainage was 5.40 and post-training was 4.50 with no significant difference from pre-training to post-training indicated for incision and drainage with a p-value of 0.590. The mean rank pre-training Laceration repair was 0, and post-training it was 1.50, with no significant difference, and was indicated for laceration repair with a p-value of 0.157. The findings in this project highlighted the need for ongoing educational experiences, which will be implemented monthly at my site, which is my organization's largest. The CPS training will also continue in this organization's NP residency program. Additionally, this DNP project opened opportunities for networking, educating, and increasing access to care. My project had several strengths that contributed to its quality and impact. The study's retrospective chart review design appropriately evaluated the effectiveness of the training intervention by comparing outcomes. This also provided a cost-effective data analysis plan. The research question was straightforward, creating an effective educational tool that could be measured in a clear direction for the project. Additionally, the data collection efforts reduced bias and guaranteed privacy, ensuring the validity and reliability of the study's results. There was also adequate participation, with almost half of this organization's NPs attending the CPS training, offering a healthy sample size. The most notable limitation was time. 1 year before and after the intervention, I feel like would be ideal to identify its impact. I recommend that more time be utilized to capture data on this project, which I do plan to do. Another limitation was this project's patient population. So CHTs face transportation and financial constraints pretty commonly, and they create high no-show rates and inconsistencies in care. This possibly impacted the product by resulting in unpredictable appointments. Also, each clinical setting in this project varied in procedural visit exposure, limiting the NP's exposure to procedural care. And lastly, this project did not anticipate the limited support at smaller sites in my organization. Though we have collaborative physicians, only some provide procedural care, and not all sites have on-site access to a full-time physician. The project did not have a process to offset the lack of support at the smaller sites, limiting the comfort of completing procedural encounters. Inconsistent and limited CPS training and NP educational and clinical experiences has produced NPs who do not feel fully equipped for common primary care procedures. And my project produced a CPS training that applies to all primary care settings where NPs work, demonstrating a high generalizability. This has also provided a sustainable model to replicate for additional primary care procedural topics, furthering NP knowledge base and access to care. However, this project does not apply to settings outside of primary care. Though the results were not statistically significant, this DNP project created a substantial opportunity for NPs in my organization. Time constraints are a notable barrier because they limit the collected data, possibly impacting its outcomes. This project utilized 6 months of data pre- and post-training, and this inhibited the ability to compare the procedural needs in all 4 seasons. Financial barriers also existed with limited funding options for this project. The new NP residency program cannot be funded until it's accredited, which cannot be accomplished until after its first year, which we are coming up on. Another barrier was the organizational infrastructure, offering limited collaborative resources and training for NPs. This directly impacted the project by limiting NPs at smaller sites who did not feel they had support if they had procedural questions. One facilitator was the ease of access of data. The clinical director of this organization obtained data through a retrospective chart review 6 months before and after the CPS training without any barriers. Another facilitator included the collaboration with physicians to produce the training material. They provided expert opinions about the subject matter and approved the PowerPoint slides, which gave this CPS training additional validity. The third facilitator was a clear research objective. With a rapidly expanding NP field and more NPs filling primary care gaps, recent research has expanded to include the readiness of the current NP workforce. The Want et al. 2022 study was one of the main inspirations for this quality improvement project, identifying the inconsistent nature of the NP procedural education. Lastly, the director of the NP residency program of my organization allowed this DNP project to be utilized by the first cohorts, and the director participated as well, providing additional feedback on the training. While I did expect an increase in NP procedural encounters after the CPS training, the results were statistically insignificant. Nonetheless, the clinical impact has been substantial due to the ongoing CPS training inspired by this quality improvement project. Recent studies have shown that additional NP training improves cost, competence, and access to care. and they support additional CPS training to enhance access to common primary care procedures and research continuation. I do plan to continue the CPS training research and improve future outcomes by increasing resources to smaller sites and expanding joint injection practice. These factors and additional comparison time would likely yield more significant outcomes. However, these studies are all very new, and I would recommend that additional research on this topic be conducted to continue evaluating the educational procedural needs of NPs. My organization does not provide internal NP educational training. This product has successfully introduced CPS training for 4 common primary care procedures with the anticipated growth of providing more CPS topics within this organization, which could also be shared with other CHCs. As for the implications of healthcare policy, NP scope of practice legislation has been widely debated. NP organizations continue to advocate for full practice authority across the United States and territories, with only 28 states extending full practice. Full practice authority has been a contentious topic as varying medical associations offer mixed support, but the CMP product aims to support NPs through CPS training to close care gaps further and support NP autonomy. The CMP product aimed to increase access to procedural care within a CHC organization by implementing CPS training for its NPs. It provided no statistically significant outcomes, but its clinical impact has been considerable. Continued integration of the CPS training within this organization intends to advance accessibility to NP-led procedural care. This will be spearheaded through sustainability and dissemination processes to gain additional support and advocacy to integrate CPS training further. This will be accomplished through a few different means, such as networking with other regional CHCs and further integrating this training within my organization. To ensure sustainability, I plan to prepare more evidence-based CPS training and ongoing monitoring and evaluation of this resource. I have already begun implementing a monthly NP training session at my site, which is the largest in my organization. And we also have CPS training scheduled for our second cohort of NP residents in the fall. My plan for dissemination includes stakeholder involvement on various levels. One is to continue involving my NP colleagues at my site with additional monthly education sessions. And I hope to grow this and offer it to all the sites within my organization quarterly. Additionally, as these educational sessions evolve, addressing this organization's board of directors will be imperative to gain support to provide CPS training routinely. Dissemination will also involve regional NP organizations and conferences, which will yield, at least hopefully, wider audiences, collaborative efforts, and networking opportunities to discuss CPS training and its impact. This quality improvement project harbors the potential to expand access to procedural care for underserved patients within CHCs and to generate support for NP autonomous care. Thank you so much for watching my presentation, and these are my references. And I look forward to your feedback.